Hi, everyone. My name is Michael Stewart. I am the Director of Education here at the OI Foundation, and I want to welcome everyone to this evening's talk. We're going to be doing a research update on the BBDC's longitudinal study with Dr. Reid Sutton, who is with us here today. Just real quick, I want to go over some basic housekeeping before we dive into today's topic. So today's session is going to be roughly 1 hour long. And we are excited we're going to be covering a lot of topics during today's discussion. During the main presentation, we ask that, so we're going to ask everyone, please keep their microphones muted if they are not already. That way we can best share the information, and keep those microphones muted the entire talk. During the talk, if you have any questions, we welcome you to type those into the chat. And we're going to have some time at the very end of today, at the very end of this evening's talk, to answer hopefully a few audience questions. So we'll try to get to some of those then. And like other OIF big medical talks, we want to remind people that these meetings are not telemedicine, so we cannot answer specific individual medical questions. We're going to be talking about research and the overall research trends that have been happening. Dr. Sutton's going to get more into that in just a bit. I want to introduce Dr. Reid Sutton, who with the OIF holds or wears many different hats and does many things for us. So amongst other things, he is a professor at Texas Children's Hospital in the Skeletal Dysplasia Clinic and also at Baylor College of Medicine, the Department of Molecular and Human Genetics. That's over in Houston, Texas. He's also the director of their medical genetics residency program and the medical director of the Biochemical Genetics Diagnostic Laboratory. In addition to all of that, he is also on the OIF's board of directors, as well as on the OIF's Medical Advisory Council, or the MAC, we sometimes refer to it as. And in addition to all of these things, he is also the administrative director and one of the principal investigators for the Brittle Bone Disorders Consortium, which is part of the National Institute of Health, or the NIH's Rare Disease Clinical Research Center. And he's going to get more into that in just a moment. But Dr. Sutton, thank you so much for being with us.
Thank you, Michael, very much for that kind introduction. Michael, are you able to see my slides okay?
Yes, we are. Thank you.
Perfect. Great. And also, I want to thank everybody for attending and thank the OIF for giving me the opportunity to talk about this collaborative research. You'll see that I'm representing many people, and not only many researchers, but many people at the OIF who have been working very hard on the Brittle Bone Diseases Rare Disease Clinical Research Network trials in order to advance care for osteogenesis imperfecta. I'm going to start by doing a super brief one slide kind of history of everything. I'm going to talk about the longitudinal study, but I'm also going to talk about other studies that have either been pilots or related to the longitudinal study, including things like quality of life, particularly around anxiety, pain, and pain interference, oral health and craniofacial development, growth. I'm going to talk about a phase 1 drug study and the progress on that, as well as the OIF educational toolbox. So the objectives today are to describe recent advances in OI care, to describe how patient-reported outcomes tools can be used to assess response to intervention in individuals with OI, to list factors that affect oral health and quality of life in individuals with OI, and describe how linear growth or height varies by type of OI and the factors that could affect growth. As I mentioned, I'm just going to start with a very brief history. So the Osteogenesis Imperfecta Foundation and the Children's Brittle Bone Foundation, back a number of years ago, around kind of 2008, established a group of linked clinical research centers with the goal of advancing care and knowledge of medical issues surrounding OI. They initially funded 3 clinical sites that you can see here in blue, and then subsequently added 2 additional sites. They did a great job of fundraising, and each site got $75,000 per year to conduct the study. And then there was a data collection and analysis center at the University of South Florida. The annual budget, and I'm showing this here because I want to contrast that with kind of our current funding on subsequent slides, the annual budget was between $250,000 and $500,000 per year, and we enrolled over 400, close to 450 individuals with OI in a longitudinal natural history study. And this was important, as you'll see on the subsequent slide, in establishing a research network as well as gaining knowledge, because in demonstrating that we could stand up a collaborative research network, we were then able to leverage that to submit a grant to the National Institutes of Health and get funding for additional research in OI. The funding source is from what is called the National Center for Advancing Translational Research, or NCATS, and they fund 20 rare disorder clinical research networks. You can see this is us here, the Brittle Bone Diseases Consortium, but you can see that there are various other disorders that range from things like myasthenia gravis to phenylketonuria and all sorts of things in between. You can see on this slide the kind of budget for the prior year, and that it's really kind of an order of magnitude from what most organizations like the OIF are able to raise. And so this sort of funding is very important. I also want to emphasize we're very proud that we actually have the most institutes of any of the 20 rare disease clinical research networks that are supporting research in OI. You can see here National Institutes of Arthritis and Musculoskeletal Diseases, Child Health and Human Development, Dental and Craniofacial Research, and then most recently, National Institutes of Mental Health, along with NCATS, that provides a significant amount of support every year for the Brittle Bone Diseases Consortium research. We're in our second 5-year cycle, so about year 8 of research, and I'm going to talk about what we've accomplished to date. If you want more information, and I'll show this at the end, this is the screenshot of the website for the Brittle Bone Diseases Consortium. And if you go here, it has lots of information about studies that are being conducted in the consortium. This is a map of the consortium. We've put in a lot of effort to, we and the OI Foundation, who is a big supporter of this, have put in a lot of effort to try to get a pretty reasonable geographic distribution. We are in Houston, so that's the blue star with the yellow dot. The other yellow dots are clinical centers. The blue dot is the OIF. They're in Maryland, which is a very important advocacy partner. The University of Cincinnati is the Data Management Center, and that's funded separately by the National Institutes of Health, and then a biomarker core at the University of Washington. I, along with Frank Rauch at Montreal Shriners, lead the longitudinal study of osteogenesis imperfecta, and the purpose is to conduct a multidisciplinary investigation of differences in clinical findings, disease progression, and response to therapies in individuals with all forms of OI across the lifespan. We have a series of secondary objections that I'll talk more about on subsequent slides, but these include looking at vertebral compression fractures in type 1 OI, in looking at scoliosis, causes, progression, and response to intervention in all types of OI, and dental and craniofacial abnormalities in individuals with OI. This is the graph of our recruitment, accrual, and retention. We have a goal of enrolling 1,000 individuals with OI into our longitudinal or natural history study. You can see in the far right, this is a screenshot from earlier in the week, and we are now at 981 individuals toward a goal, total goal of 1,000. I mentioned earlier the scoliosis study. So one of the things that is common, particularly in more severe forms of OI, are significant scoliosis. You can see here preteen and teenager, where there was this like fairly rapid progression of scoliosis. And then in the far right image, after rotting surgery for the spine. But one of the challenges here is we are not really sure who is at highest risk to develop scoliosis. We don't really understand the factors that may predispose to that, the rate of progression that we might expect, and then how individuals respond to treatment or interventions such as rodding, bracing, or other procedures. And so again, the aims are to determine the effect on pulmonary function and functional ability, and to evaluate the impact of current treatment approaches to do this. The procedures that are involved are a patient-reported outcomes tool or survey called PODCI, the Scoliosis Research Society questionnaire that again is another survey of patients about how they feel they are doing. And then there are these other assessments which assess mobility, x-rays of the spine, DEXA scan to look at bone density in the spine, and pulmonary function testing that's all part of this scoliosis trial. And again, we want to better understand the incidence and progression of scoliosis and correlate the scoliosis and the development with things like function, pain, and pulmonary function. So sorry, physical function would be that first one, and pain and pulmonary function. We also have a study looking at vertebral compression fractures in individuals with type 1 OI. We want to understand how often this occurs. We want to understand, are there factors that predispose individuals to develop compression fractures and who is at highest risk for that? And also determine the potential for healing, particularly in childhood in individuals with OI. The procedures here are what we call anthropometry, which is measurement of height and other factors related to growth, assess back pain, assess bone mineral density, and again, this is a DEXA scan, assess the pubertal development, again, particularly because we want to look at whether children and adolescents can heal vertebral compression fractures. And then, of course, spine x-rays to assess the degree of compression fracture, as well as any healing or reshaping. What we're using is a standard classification system where you can see these are side images of vertebrae in the spine. In the upper left, you can see what a normal vertebrae would look like if you viewed it from the side. And then this system allows us to classify the degree of vertebral compression fracture into mild, moderate, or severe. This is just a real life example of what it looks like on x-rays. These images are courtesy of Leanne Ward, whose group is leading it. She's at Children's Hospital of Eastern Ontario in Ottawa, Canada. Her group is leading the analysis of this data. These are images from her showing an individual here at 5 years who has pretty significant vertebral compression fractures indicated by the yellow and red arrows. And you can see, let me turn my pointer on here, should have done that earlier. You can see that there's kind of the vertebrae here are squished or flattened right through here, and that there is improvement over the years to normal or near normal. And we want to understand if that can happen with OI. Laura Tosi and Jeff Krischer led a quality of life study as part of the consortium. And this looked to validate patient-reported outcomes measures information system, or PROMIS tools. These are surveys that are developed for by the Department of Health and Human Services and the federal government as ways to assess how patients or individuals in the population perceive their medical journey. We used a contact registry to enroll individuals into this survey study, and the OI community, as always, really turns it out, and we had a great response and enrolled over 300 individuals in less than 48 hours. What we found was that individuals with OI have higher or more significant scores in various areas that we looked at, including things like anxiety and pain interference, notably shown here in bold, but other things as well, like sleep disturbance, satisfaction with social roles, and other things, particularly for adults, were worse or had higher scores than the general population. What that initial pilot study of those 300 individuals allowed us to do was, in working with a psychologist here at Baylor College of Medicine, Eric Storch, to apply for supplemental funding from the National Institutes of Mental Health to delve more into this and learn more about these issues in individuals with OI. The first step, or the first aim, was that Eric and his group conducted what are called qualitative interviews. These are very open-ended, one-on-one interviews. They lasted about an hour, and they were 3 groups of individuals that were interviewed: adults with OI, children or parents of children with OI, and medical professionals who care for individuals with OI. There were 15 individuals in each of these groups. And we are in the process of completing the analysis of the adult group first. We just finished the interviews a little over a month ago. As I mentioned, there were 15 participants in the adult group, a little more female than male, all types of OI, and again, predominantly white that agreed to participate. There were some questions that were asked, but again, this was a very open-ended discussion, and these discussions were all transcribed anonymously, and they were organized around recurrent themes. And what we found were there were 3 recurrent themes in the discussion with adults with OI. The first is loss of mobility due to fracture poses a significant psychological burden. And so you can see I've kind of included a few quotes for each of these. So one individual said that internal voice turns very evil because you have nothing else to do. What seems like 6 weeks to recover from a fracture can get you into very deep depression waters. Another theme that was identified was that the unpredictability of fracture as well as physical appearance relative to others could result in anxiety. And again, a couple of quotes here. I'll just be sitting there on the couch and I'll get like PTSD from a fall, or I'll start having psychological pains in my legs if I'm thinking about it. In relation to physical appearance, one individual said, I have pretty bad like social anxiety. I think there's more dudes who just when I walk into a room, everyone stares at me and like, I don't like being the center of attention, but I usually am because I'm different. I mean, I'm in a wheelchair. And then the third theme was positive orientations toward OI that buffer against adverse outcomes. And a great example of this was an individual who said, yeah, OI has definitely made me stronger. It's definitely pushed me to my limits. I've never let my disability define who I am. If I see someone that's really struggling, I give them that strength that OI has given me. Because I mean, I know what it feels like to be down. I know what it feels like to not be able to do things or fit in. What this has allowed us to do is by identifying these important areas, we will now be adding this relatively long list, although thankfully they are only a few questions each, to the natural history study of OI. And you can see, I'm not going to read all of these domains over here on the left, but again, we're going to look at things like anxiety, fear of falling, sleep quality, pain intensity, acceptance of pain, medication misuse, self-esteem, social support, resilience, and hope. And so these will be incorporated in the natural history study, and individuals who are participating will complete these every year along with their regular study visit for us to learn more about the mental health concerns and strengths across the ages, to correlate physical health with mental health outcomes. And then most importantly, Eric and his group developing appropriate psychosocial interventions tailored specifically to the OI population based upon their experience, their lived experiences. Moving on to the oral health and craniofacial development. This was led by Jean-Marc Retreby, and I'm showing here the cover of the July 2018 Journal of the American Dental Association. We are very proud of this, that Jean-Marc's work in looking at dental and oral health issues in OI actually made the cover of the Journal of the American Dental Association. So the objectives were to evaluate dental anomalies in OI, to assess the impact of dental anomalies or dental issues upon oral health related quality of life, and to look at how things change over time. On the next few slides, I am going to be showing some medical photography of teeth in individuals with OI. Here in the data gathering process, the primary things we looked at were a dental examination by dentists on the research teams at each site. We got x-rays or panoramas. So I know when I go to my dentist regularly, I get that x-ray that swings all around my head. Probably most of you do as well, but we are doing that again to get an assessment of the dental health in OI. We used quality of life or survey tools to ask individuals how they perceived their dental health. And then we took photos of the teeth as well as intraoral scans to assess dental health. One of the things that we noticed is that individuals who have Dentinogenesis imperfecta have a higher risk of developing cavities or caries. You can see over on the left a graph. These are grouped into 4 different ages that you see across the bottom. Children, preteens, and adolescents, teens to early adult years, and finally over 23 years. The black bars are individuals that do not have DI. The red bars are individuals who have DI. And you can see in all cases, the red bars indicating those who do have DI are higher, showing that they have a higher rate of cavities of their teeth. One of the other things that Jean-Marc's group found that I think was not well characterized at the time was the degree of what we call malocclusion or bite problems in OI, particularly severe forms of OI. This is most characterized by 2 things. One is normally one would expect that the upper incisors, the upper front teeth here, would come down just slightly in front of the lower incisors. And in many individuals with severe forms of OI, as you can see here, they're either meeting kind of right on top of one another, or the upper teeth are coming in behind the lower teeth. The other thing that was quite common in severe forms of OI is what's called a lateral open bite. So what this means is that on the lateral or the side of the mouth, where the molars should normally come together, that in many individuals, those molars are not coming together when they bite down. And so obviously that's going to cause issues with chewing. We also looked at how this kind of malocclusion or abnormal bite in individuals with OI influenced how individuals with OI perceived their oral health and wellness. And you can see that across the bottom here, various abnormal bites. And basically the summary is that if it's yes, that you had that particular bite abnormality compared to no, that you didn't, that overall for most of these, that the oral health quality of life was worse, reflected by a higher score for individuals that had these kind of bite abnormalities or orthodontic abnormalities in OI. Dr. Reid kind of did a little pilot of 2 individuals with OI for treatment of these orthodontic or bite abnormalities. In general, standard orthodontic brackets, so those silver things they glue on your teeth, are usually not recommended for OI for 2 reasons. One is that the DI that many individuals with type 3 and 4 OI have makes it such that it's very hard to get the glue from the brackets to stick on the teeth. So that's often a challenge. And then the way that the brackets are typically removed, if anybody there has ever had braces, is that the orthodontist just takes a pair of pliers and like snaps them off. And then again, obviously if people have Dentinogenesis imperfecta, which often causes chipping or fracturing of the teeth, that's not a great idea to be putting that amount of force on a tooth. And so there is this system that many people have probably heard of called Invisalign being the most common brand, but there are other brands of these clear plastic aligners that kind of go over the teeth. To move it, you can see individual up here that again had this lateral open bite, and another individual here undergoing this Invisalign system. So here they have on the clear plastic aligners. This individual also got a couple of little posts and rubber bands to try to move things. And you can see here at the bottom, good response to treatment in this individual with OI using these clear plastic aligners. And so we just started enrolling a couple of months ago, a larger clinical trial of this Invisalign system. Again, this is funded by the National Institutes of Health, and the investigators include Dr. Janice Lee, who is at the National Institute of Dental and Craniofacial Health, as well as Dr. Reid. The goal is to assess how effective and safe this invisible aligner system is for individuals with OI and orthodontic issues. There's going to be 57 children and adults with types 3 and 4 OI, because they're the ones that typically have these significant bite abnormalities. They have to have a certain degree of bite abnormality that's assessed by something called the peer assessment rating or PAR score. And then there will be initially kind of 4 months of observation, followed by 12 months of the aligners, and then another 12 months as needed to try to complete or get the best correction possible. This will assess again safety, as well as this rating score that is an objective assessment of improvement. There are some patient-reported outcomes tools and other things. My favorite outcome that we're going to be looking at is what's called the masticatory gum test. So this is a test in how well you can chew. This gum, we ordered a couple of cases from Japan where it's made. The gum is out of the packet is that green appearance that you see over here on the left. The green dye that's in that gum is visible when the pH of the gum is acidic. And it has an acid called citric acid that's used as a preservative in a lot of things in the gum. And so out of the package, it has this green color. As an individual chews this piece of gum, the citric acid leaches out into their saliva. And there's a red dye in it that is predominant at neutral or high or alkaline pHs that can be seen. And so this is an example over here on the right of what it looks like after it's been well chewed. And so we're actually going to be assessing as the orthodontic Invisalign system moves the teeth, is how much is that improving an individual's ability to chew. So I like that one. I think that's a fun one. Now I'm going to talk about growth in OI. This was led by Frank Rauch at Montreal Shriners. One of the things that we have known for many years about individuals with OI is that they tend to be short. Individuals with the more severe type 3 and 4 OI are short compared to the general population, but even individuals with type 1 OI, while they may be kind of in the normal range for the general population, when you look at their height compared to other family members, they're shorter than would be expected for other family members. Some individuals have attributed this to the fact that individuals with OI can have scoliosis, which can affect height, or can have bowing of the bones or bone injury due to fractures of the bones and poor healing that maybe make the bones short. Frank wanted to look and see, is that really the case, or is there something else? And so as part of the longitudinal study, the natural history study, everybody got hand x-rays. And so what Frank was able to do is to take the hand x-rays and look at the length of the metacarpals, so the bones here in the hand, because even in severe forms of OI, people typically don't have a lot of fractures and deformity of the metacarpals like you would have, let's say, of femurs or other bones. And what he saw overall in all types of OI, type 1, 3, and 4 OI, is that their metacarpal bones were shorter and other bones in the hand were shorter than would be expected for the general population. So this line here is at 0 is the average for the general population. And you see again, type 1, 4, and 3 OI, and all of these individuals, their bone lengths in their hand are shorter compared to the general population. This also, when looked at, again, was statistically significant. You see that over here, this is a correlation between height across the bottom and the length of the bones in the hand. And you see that there's a very good correlation with height and bone hand length. And so what this indicates is that the short stature in OI is due to abnormal bone growth. So it's not all fracture or scoliosis related. There's something intrinsic about the bone. It could well be kind of collagen, an abnormal collagen causing problems with the cells in the bone that are grown. But certainly, again, these studies indicate that there is a bone growth problem, not just a bone fragility problem in OI. Sandesh Nagamani, who's on, led a phase 1 study of the safety of a drug called Fresolimumab in Osteogenesis Imperfecta. So Dr. Brendan Lee, my department chair here, and the overall principal investigator for the Brittle Bone Diseases Consortium, has a lot of research in his laboratory on osteogenesis imperfecta, including various types of OI. This is vertebrae kind of cut in cross section with OI. Normally what you should see is something that looks like this more here on the right, with these like little bony spicules in the middle of the vertebrae. And you can see here in this mouse model of OI, there really is not kind of this degree of kind of bone connection inside the vertebrae here in the mouse model. And what Ingo Graf, one of the former OIF Geisman fellows, found is that in individuals with both kind of mice with CRTAP OI, as well as the common type 1 collagen OI, have an increase in a signaling pathway that tells the body how to do something, or tells the bones how to remodel and build up new bone. And that signaling pathway is called TGF beta, for transforming growth factor beta. And what Ingo did is he treated these mice with OI with something that blocked this TGF beta signaling, and you see near normalization of the bones in those mouse models. And so what Sandesh did was to develop a phase 1 drug trial. Phase 1 drug trials primarily look at two things. They look at kind of what's the highest dose that an individual can tolerate, and then how safe is a particular medication. So just very quickly, we do also collect outcome. You can see here at the low dose, individuals with type 4 OI got an increase in bone density. Severe forms less so, but when we looked at the higher dose, they overall got kind of a good response and increase in their bone density after receiving this drug, Fresolimumab. One of the important things is for the consortium is to generate data from the longitudinal study or other studies that will get drug or biopharma companies interested to develop new therapies. The main reason for this is that these are very expensive trials to conduct, and most budgets of the National Institutes of Health or other things are not sufficient to support it. I'm very pleased to report that Sanofi, that provided that initial drug, Fresolimumab, to us for free for Sandesh to do the phase 1 study, has now developed a new form that is longer lasting. It's got this lovely name, SAR 439459, and they are conducting another phase 1 safety study in adults with OI. You can see the details here. There is one center in the United States that's open, and they anticipate opening other centers as well. And again, this is all based upon the data that came from the Brittle Bone Diseases Consortium about this potential new therapy. Finally, I want to say that a portion of the funding that comes from the National Institutes of Health goes to the OI Foundation to develop resources for individuals with OI. I want to highlight here on the OIF website that there are a series of toolkits that have been developed as part of fundraising efforts from the OIF and the grant from the National Institutes of Health. These also include things like video conferences for medical professionals that are highlighted over here on the right. There have been a number of publications in various journals that I've not had the opportunity to talk about tonight, but this spans everything from pregnancy and birth, a lot about oral health, as I had mentioned earlier, looking at response to rotting in OI, I mentioned the growth characteristics, looking at physical function, hearing, and again, kind of pregnancy. So if individuals are interested in participating in research, we would love to have you join us. As I'd mentioned, we still have just about 20 individuals we're looking to enroll to complete 1,000 in the natural history study. I'd mentioned the Invisalign orthodontic trial that's being conducted at the National Institutes of Health in Bethesda, Maryland, at Kansas City, as well as Los Angeles. Deb Krakow has a study looking at women with OI and their pregnancies, particularly centered around blood loss and needs for transfusion. I'd mentioned the new drug trial that's built upon Brittle Bone Disease Consortium work. I'd mentioned the anxiety and pain. And then we also have a pilot cardiopulmonary trial led by Kathy Raggio at Hospital for Special Surgery, as well as Sandy Sandhouse. So how do you find clinical trials? This is a website link for our Brittle Bone Disease Consortium. The OIF regularly posts information on their website, as well as sending out emails regarding research studies that people can participate in. And then this federal website, clinicaltrials.gov, has a listing of all research studies, and any research study that's either funded by the National Institutes of Health or that is regulated by the U.S. Food and Drug Administration. They must post the research trials to this website. As you might imagine, I could not have done all of this alone. And so you see over on the left, the various sites and researchers, the funders from the National Institutes of Health. And again, we're just really excited and honored to have so many institutes, more than any other rare disease clinical network, that's interested in funding OI research. And of course, finally, you and the OI community and the OI Foundation, because none of this research would be possible without your support and participation. So thanks very much, and I'm more than happy to take any questions.
Dr. Sutton, thank you so much for that very thorough overview. You covered so much information that I'm almost not totally sure where to begin. I want to remind folks, if they have any questions, feel free to type that into the chat and we'll try to get to as many as we can. I'm going to, though, jump in and ask some questions first. So you covered a lot. And also the longitudinal study, it has many different parts and has been going on for years and years. I'm going to go back to a little bit sort of the beginning part of your talk, talking about specifically like the funding and also like how that impacts the future of it. So we know that the NIH is funding a large chunk of this study. But also like that is something that we have to apply and reapply for. And even though I think it's very clear that the entire team is doing really excellent work and is setting the benchmark in many ways, I guess like what happens assuming we get this funding renewed, and what happens if, say, in the future we don't?
That's a great question, Michael. Thank you. So, so the National Institutes of Health, the policy that they have for these rare disease clinical research networks is that any research network, they can have funding for no more than 3 5-year cycles, so 15 years, and then they're cutting you off. Okay. And so we do have metrics for each year that we have to complete. So things like, you know, the enrollment of 1,000 individuals is a metric for us, and other sorts of things. And so publications are a metric for us. Completion of studies we say we're going to do. Those are all metrics, and those are all very important metrics for us to achieve when we go to reapply for funding. We can, in 2024, apply for our last cycle of funding from the NIH. I think what, you know, we will start kind of in the next kind of 6 months or so planning for that resubmission that will happen in the fall of 2024. There are a lot of things that we will need to discuss about the longitudinal study. Again, kind of things like, well, how much data do we really need, right? And in this next funding cycle, do we continue doing the same thing we've been doing for the longitudinal study? Do we take what we've learned and focus that now on specific areas and all those sorts of things? So, I mean, I think we're very hopeful that we will get refunded. There's never any guarantee for that. But again, I think we would hope that as long as we're able to meet our metrics, which we generally have been so far, that we would be refunded.
Thank you. So looking at the more like recent past, how have current events, particularly around COVID and reduced visits to hospitals, has that impacted the work of the BBDC and specifically the longitudinal study at all?
Absolutely. And but if people were paying attention when I showed that graph of enrollment, you saw we did really well for the first few years. And then about the time COVID hit, all of a sudden we weren't kind of had a big slowdown.
Mm-hmm, mm-hmm.
Obviously, many individuals with OI had concerns about coming in for their annual study visits, but also, at our institution and most all institutions, elective procedures, whether that was an elective surgery or a research visit or other sorts of things, they were shut down for quite a number of months. Now, the good thing is that everybody on the team worked really hard to make sure that we were still meeting our NIH goals for what we were supposed to accomplish during the study. So it did have an impact. We actually, it seems like, have not kind of lost a lot of individuals to follow up, as the centers over the last kind of year and a half have started having people back for their natural history study visits. All the sites are generally doing a great job, and all the participants are also doing a great job in keeping engaged with us. And so, of course, we need to thank them as well.
Mm-hmm. Absolutely. It seems like very hard work, even under the best of conditions. And it's just very exciting to see that it hasn't really slowed down much. I want to bring up a thing that when we were prepping for this meeting, you had, it was something that I actually had learned. I was less aware of this, how these systems work together. But in your talk, you had talked a bit about how various pharma companies are using this research. Can you talk a little bit more about that, of just what is the relationship between specifically the longitudinal study, this natural history study, and how that relates to other OI related treatments being studied now and down the road?
Absolutely, Michael. So, one of the goals actually of the National Institutes of Health is that these rare disease clinical research networks will partner with biopharma or other commercial entities to advance treatments and advance care. And so this is really a central part of the mission and something that we're very committed to. One of the challenges with rare diseases is that when a drug company comes into a rare disease space, it's almost always true that the understanding of the natural history of the disease is inadequate for them to plan a clinical trial. And so increasingly what happens if there's not this sort of network in place is that the drug company has to conduct their own clinical trial. If people are familiar with achondroplasia, the most common form of severe short stature, the drug companies that are in that space, they had to actually conduct their own longitudinal or natural history study. We've got the benefit that we now have this data from the natural history study that biopharma companies can use to plan their clinical trials. And this makes it more attractive to them because they don't have to spend all their money doing a natural history study. They can come to the Brittle Bone Disease Consortium. So we have provided to two biopharma companies so far, Ultragenyx, which is conducting a trial of a drug called Fresolimumab in children with OI, so that they can plan their clinical trial and know when they go to the Food and Drug Administration what outcomes that they're going to look at and argue their case. And as well, we've provided similar data to Sanofi that I'd mentioned earlier that has this anti-TGF beta trial, again, that is starting in adults.
Great, thank you. Very exciting. I've got one last prepared question, and then I'm going to switch over to some of our audience questions in the chat. So my last question is about, so whenever the longitudinal study is, I'm going to put an air quote, done, will those results be relevant forever? Meaning, like, so this is the longest, I think it's safe to say this is the longest and largest study of people with osteogenesis imperfecta, the
by far.
countless man hours of work and 1,000 patients. And when this is done, is this something that will last for the foreseeable future, or like 10 years after it's done, 20 years after it's done, we'll be doing this again?
Yeah, that's a complicated question, Michael, and there
Okay.
are kind of
Okay.
multiple parts to that answer, but I'll try to get to
Okay.
them all succinctly. So one is that the Data Coordinating Center at Cincinnati Children's University of Cincinnati, they have all the data. It is de-identified, so it's safe and secure, and it's in a cloud. So that data itself is essentially kind of evergreen. So that data will always be there in the cloud. Individuals, researchers can access that if they request, and as long as they provide documentation that they have authorization to conduct the research. So that, and we even now currently have people that will ask the Brittle Bone Disease Consortium who are not members for data. And again, if they have a good proposal and authorization to conduct that research from their institution, we will provide them data. So this data itself is everlasting. Now, the more complicated thing is going to be, as new treatments come on, how relevant are things going to be? So that's always an issue, but I would say that I would think for the reasonably foreseeable future, meaning in the next kind of 10 years or so, that data is still going to be relevant. And not only is it going to be relevant, it's going to be available if researchers want to go access that data to understand and learn more about OI.
Gotcha. Thank you. So I see some questions here in the chat. I see a few different people are asking about, is there any work or research being done around or like addressing the needs of particularly postmenopausal women with OI? Can you speak on that at all?
Right. So, if we look at the longitudinal study of OI, I see there are lots of women on the call this evening with their cameras on, and that's great. And that's the exact same response we have to the longitudinal study, particularly in adults. We look at children, it's kind of 50-50 males versus females. Most of the adults, if we look in adults in the longitudinal study, it's actually about 70% female, and we males are not doing a great job representing in the longitudinal study, I must say. We are collecting things like DEXA scans, bone mineral density scans in individuals. And so we've not analyzed that data specifically in postmenopausal women with OI, but we do have a lot of data there that could be analyzed, absolutely.
I also see a question here around, is there any work being done around, or any studying around reclass infusions or similar drugs?
Right. So the only drug trials that we have done as part of this longitudinal study are the one I mentioned with the Fresolimumab, the anti-TGF beta antibody. Certainly there probably are, so you can enroll in the longitudinal study irrespective of whether you're receiving a treatment from your local treating doctor. And so there are individuals in the longitudinal study, certainly many that are on bisphosphonates. So, probably some that are on other medications as well. And again, one of the things that we'll be doing when we look at various things, again, like scoliosis and vertebral compression fracture or other things, are, we know who's on what medication when. And so we can try to understand, like, if you're on a bisphosphonate, does that lower your risk for scoliosis, right? Or does that lower your risk for vertebral compression fractures? And so it would depend upon how many individuals we have on a particular medication, again, like reclassed. But that data is there. But again, we're not conducting a specific kind of reclassed trial.
Got it. Okay. I also see another question here, and I'm going to direct this person. So there's a person asking about, are there any dental panoramic X-ray machines that accommodate people with type 3 OI? I actually think this might be a question better suited for Dr. Retrove. To the person who asked this question, feel free to send the OIF an email directly at bonelink@oif.org, and we can put that in the chat in just a second. And we can forward that question to some of our medical advisory council members, like Dr. Retrove, who was just referenced before, who is doing that malocclusion study of all the teeth. And he will probably be the person to answer that question if we can get something for you. But we want to make sure that we see your question. We're not ignoring it. Do we have any other questions from the audience in our last 3 minutes with Dr. Sutton? So unless somebody jumps in with a last minute question, I really want to just wrap up by asking, so you've given us a kind of a big overall, overview of this giant, very ambitious study. Are there things that, is there a thing that most excites you about what the study will do for people living with OI?
Yeah, I think, back to what we had discussed just a few minutes ago, Michael, the fact that this is really going to be a repository of data. I talked about a lot of things, but we still collected a lot of data. The question about, women with OI and postmenopausal osteoporosis and whether they experience that differently than the general population is a great question. It's one of these things that, golly, like there are a lot of people working on this, but we all still have so many hours in the day to get this stuff done. And so we certainly welcome other researchers to come and look at things, or again, it may be that, as I mentioned earlier, if we get funding for the third phase, that maybe we don't really do much at all in a natural history study, that's very focused, and what we spend our efforts on is not so much these annual study visits, but it's really kind of analyzing the data that we have that's been generated. So I do think kind of one of the most exciting things is, again, kind of having all this data, having it all collected kind of at the same time on individuals with OI, and that we can kind of really understand and correlate all sorts of things like, again, everything from scoliosis to pulmonary function to quality of life to bone mineral density. We do a 6-minute walk test. How far can you walk in 6 minutes, right? All these things we can correlate together to really get a full picture of the lived experience of individuals with OI. So I think that's the most exciting part. I am also very excited about the study that Eric Storch is leading on pain and anxiety. This is something that was a little bit of a surprise, honestly, that we had submitted it as part of the natural history study in our second round of funding a couple of years ago. And what we got back from the National Institutes of Health was, we think that's kind of a good idea. The National Institutes of Health, National Institute of Mental Health may be willing to kick in money, but you need a psychologist on there to know what they're doing for the study. And so what we had initially put in as like a longitudinal study item, they actually wound up funding a much bigger chunk than we were asking for in the first place. Now, we did have to go back and do a little more work, and Eric to help us with that. But again, I think that's very exciting, and the National Institutes of Mental Health has really been a great partner. And we, again, would hope that that would continue and would anticipate that, again, in this final cycle of funding, that we would really have a substantial component focused on various mental health issues, pain and anxiety, and other things in OI is a really big piece of the grant that hopefully the National Institutes of Mental Health would be willing to support.
Great. Dr. Sutton, thank you so much. As always, it is a pleasure to talk with you and to learn from you. on behalf of the OIF, thank you so much for taking the time to talk with us. If you have more questions for the foundation, feel free to email us at bonelink@oif.org. I saw my colleague Erica put that into the chat already. And I hope everyone has a good evening.